hosting us today and to be brave enough to have this as our inaugural live stream on YouTube. And I'd also like to thank my staff, who without them, we could not do that. And so first up, we have Olivia Hunter, who is our Marketing and Media Production Associate Director. We also have Candace Cousins-Hopkins, who is our another Associate Director for Community and Government Relations. I actually know what they do. I have Nancy Anabi, who is our Community Liaison and works with the Ashling Center to bring programs like this here. Also, I have Sue Arditi, who works very closely with the hospital. And finally, Jay Latorre, who is our Media Production Manager and is the one who's sweating, making sure that we can get all of this done for you. So we appreciate our original community partners, and I need to just acknowledge them because since we started doing these educational programs, they originally were on teams, and the Yonkers Neighborhood Naturally Occurring Retirement Community and the Yonkers Public Library were our original partners to help us get the word out. But we've added since then the Ashling Irish Community and Cultural Center, the Department of Veteran Services of the City of Yonkers, Ardsley Parks and Recreation, Ardsley Senior Center, Bronxville Community Center, the City of Yonkers, Community Baptist Church, Hastings Community Center, Irvington Community Center, Westchester Jewish Community Services, and Yonkers Pathway to Success. So we thank all of our partners, and we appreciate their support. For everybody who's watching live on YouTube, please post your questions in the comments section. And at the end of our interview, we will do our best to answer any questions that have not been answered during the talk. So now I would like to introduce you to our guest today, Dr. Stephen Erosa. Dr. Erosa is dual board certified pain physician who focuses on rehabilitation and advanced interventions to help manage chronic pain, something I think we all might have an experience with. He graduated from Philadelphia College of Osteopathic Medicine and completed his residency program and fellowship at Montefiore Medical Center. And he is currently practicing at St. John's Medical Group in Yonkers. Dr. Erosa is a dedicated physician who aims to provide treatments for his patients that have long-lasting effects. So welcome aboard.
Thank you for having me.
Absolutely. We're so excited. So let's just jump right in and sort of get an idea of what chronic pain is. Can you define it for us?
Sure. So chronic pain, by definition, if we're going to talk about it from a medical perspective, it's any pain that lasts longer than 3 months. That is the cutoff. Most things that hurt you, whether you have a fracture or a cut or a surgery, they should get better within 3 month time period, and you shouldn't have persistent pain afterwards. So if it keeps nagging me for months, years, even decades, that would define a definition of chronic pain. And that is all types of pain, whether it's a nerve-related pain. Oh, am I not catching the mic? Hold on, let me get off this.
Yes, adjust.
I have to scooch over. This thing's very springy. It's like a pogo stick.
Yes, it is.
Sorry about that. So this consists of all types of pain, whether it's a nerve-related pain, that numbness, tingly, burning, that deep achiness type of pain, or like an arthritic, joint-related, throbbing sort of pain. They all are connected, and they all can last longer than 3 months.
So can you share the basics of pain treatment?
So fundamentally, when we talk about treating pain, the first thing is, let's treat the underlying condition, right? So if there's a problem there, if we can fix that problem, then the pain should go away. If that pain persists, the different modalities we have, which many people may either have had themselves or know of other people that have done this, we all know about medications, right? Tylenols and anti-inflammatories, nerve pain medications and opiate medications. There's all types of medicines there. And then there are physical therapies. So doing for musculoskeletal pain complaints, meaning bones, joints, nerves, doing exercise can help with that pain. And then after that, when we're still in that sort of situation where we're not getting much better, There are other types of interventions.
But before you continue, can you talk a little bit about what your thoughts are about medications for pain? Because that is something that everybody does. We all reach for the basics, the Tylenol and the Advil, and I know it does progress from there. So can you just give us some background on and your thoughts about that?
Sure. So when we're talking about the regular over-the-counter medications, they are considered to be safe, but it also depends on your health and the state of your health conditions. There are certain medicines like ibuprofen and anti-inflammatories that aren't great for people that have heart problems or GI upset, like stomach upset, or ulcers or things like that. So we have to be cautious when utilizing those medications. And then when we talk about chronic pain, a big topic that's been popping up on the media and the news over the past 10 years and has found its way into documentaries on Netflix and TV shows on Hulu and all these things are the opioid medications. So long-term opiates for decades have been the go-to for chronic pain. The problem with long-term opioids is that they were never developed to treat chronic pain. They were made to treat acute pain, meaning pain from a surgery that lasts for days to weeks. The long-term effects of that opioid use, of using opioids for chronic pain, can be very detrimental to your health, can cause things like addiction, and alternatively, and depending on how it progresses, even death when patients overdose or take too many of them. When we talk about patients that are over the age of 65, the way we metabolize medication is very different than people under 65. And so when we talk about utilizing medications for pain, sometimes we want to do a little bit of Tylenol, we want to provide a little bit of like a nerve pain medicine, maybe another opioid, but those medications can have a lot of systemic effects, dizziness, sleepiness, can increase risk of falls. So when we have some of those conditions already without taking those medications, medicines that we think will help can actually cause a lot of secondary effects that may not be beneficial or could be detrimental to your health. So my opinion in our practice and the way we've built the practice is we are going to utilize all of the advanced interventional treatments to get to the source of the pain so that we can minimize the use of long-term medications. And it is my belief in our practice that if you haven't tried these interventions, then you have not exhausted all options for pain. And that's why in our practice we're not prescribing long-term opioids in the beginning. That is something that we would reserve as a last resort, and we have doctors in our system that can help with that.
So before we get to anything else, I want to go back and talk about chronic pain. And most people know arthritis is a big cause of chronic pain, but can you go over some of the other things that would be relatable to this audience that cause chronic pain?
Like specific types of different diagnoses
Yeah,
about arthritic pain versus nerve pain.
Mm-hmm.
So some of the different things that do come up in our practice are things like diabetic peripheral neuropathy. We have interventions for patients that have that are not just the typical medications and creams and things. When we talk about arthritis, yes, we all know that an arthritic knee can hurt or my low back can hurt. But we also can talk about patients who have had surgery. I had a knee replacement. My knee still hurts a little bit. What do I do? We have several interventions to help with chronic post-surgical pains, where in many instances, a surgery can be perfectly successful. Every x-ray looks perfect, the joint moves well, and your surgeon may say, this looks like a great, name the procedure. But you still feel uncomfortable. That happens in a 10, 15, 20% of patients that get any specific type of surgery. It depends on which surgery it is. But there will always be a small percentage of people that are not 100% better. We have treatment to help with that post-surgical pain.
So let's talk about some of the things. And actually, we did another program with Dr. Erosa called Riverside Reflections that he talks a little bit about why he chose pain medicine and the things that have come into play just in the last few years, maybe last 5 years, maybe a decade, And that's what we're going to really explore today. So we're talking about, and I actually don't like this term, cutting-edge treatments, because it sounds so harsh, right? But they are new procedures that are very, very wonderful, and they are minimally invasive.
Yes.
Okay, so minimally invasive procedures, that's what we want to know. So the first one I know about is peripheral stimulation. Can you talk to us about that?
Yeah. So peripheral nerve stimulation is a treatment where we're using electricity to change the way you feel pain in a given painful area. It's very specific to a specific part of the body. It's the treatments that we use are approved anywhere from the head all the way down to the toe. So we can utilize this treatment. The beauty about this one particular device that we use is called is a temporary 60-day treatment. So when we talk about stimulation as a treatment for chronic pain, it's been around for decades, since the 60s or 70s when the first implant was performed. And over the years, that technology has gotten better and better and better to the point where, for the first time in history, we have a device that you do not have to have permanently implanted in your body that can help you have long-term pain relief after only 60 days of treatment. And so the minimally invasiveness of this is that we do it, we place this little wire, which is the size of a hair, through a needle. It's done like you do any other injection that you would have done in the office or at the hospital before a procedure. We do it under ultrasound guidance, so we can scan and look and see exactly where we're going, or we do it under X-ray guidance, so we can see exactly where the lead is going to go over a particular body part. Instead of injecting medicine, I connect a little device to the wire and we stimulate it. Patients will feel a comfortable sensation overriding where they have their normal pain. And then once that's confirmed that it's exactly where we want it, the needle comes out, the little wire stays half in and half out. We put a little glue, skin glue, on the skin, cover it with a Band-Aid, and there's a little device that clicks to it, and you would run that treatment every day for 60 days. When that 60 days is over, we pull it out. It just slides right out. You have to be careful with it because, honestly, anybody could accidentally pull it out. But that's the beauty of the device. It comes right out. There's no sutures. There's no incisions. There's no long-term foreign body, the device inside of your skin. And when people do very well with it, they can get up to a year or even longer of pain relief. And so that's why I really like that device. It's the only one in the world that we have that does that, that's not a permanent implant. And as of to this date, we have done the most implants in the United States.
Yes, I was just going to get to that. You beat me to it,
I know,
Doctor.
it just goes in that way.
That's right. Okay. But there's also a permanent option for that.
Correct. So the next question everybody says is, okay, so what if I don't get that long relief? What if it comes back? You said 1 to 2 years. So if you feel better, but the pain relief doesn't last. So let's say we put it in and you're doing great. 2 months go by, you're like, this is the best thing I ever had, Dr. Erosa, thank you so much. I pull it out, a month goes by and your pain is starting to return. If it's starting to return, we've identified that if we stimulate that nerve, you will get pain relief. And then I have several other devices that we can place through the skin that stay under the skin.
Kind of like a pacemaker?
So yes and no. So there's two types. The actual one I'm talking about now is less invasive than that.
Okay.
All through a small, we call it a stab incision, a little poke, so it's like a millimeter. I place this wire under the skin with a needle and some numbing medication, like a shot, and then we get the stimulation. In that same tiny spot, we place that little needle in another direction, and we slide the wire in, we break it away, and it goes underneath the skin. We glue that shut. You're awake during this whole thing because we just do it under local. Put a little bit of numbing on the skin, put it in, and then you could use that wire or that pain relieving device whenever you have pain. So if you have pain, turn it on, turn off the pain, or reduce the pain.
I like that.
And to your point about the other device, if you want to talk about that, we could talk about that.
Yes, we should, but before we get to it, I want to talk about spinal cord and DRG stimulation as well. So can you talk a little bit about that?
Absolutely. So now we're kind of going from everything. So everything that I'm talking about today is all considered minimally invasive compared to open spine surgery, open joint replacement procedures and surgeries. And what we're doing is we're going from the least invasive to the quote unquote most invasive of the minimally invasive treatments. So let's say we do something or we try this device and it doesn't help you, or let's say you're just not a candidate. I just don't think that the temporary procedure is a good one for the pain that you're talking about. There are devices where we do a week trial. We put a little wire around a nerve and we stimulate that nerve at the back level. So in the spine area, like we were doing an epidural. You try it for 1 week. If it changes your life, you feel better, you're walking longer, you're sleeping better, your pain is better. When I take that one out, that one doesn't have a carryover effect that is long. That is just a test drive to see if you would use this device long term. And it's like a pacemaker. So if anybody knows what a pacemaker is, it's the same sort of technology, just changed to control your pain. Yeah.
Okay, so for those devices that you've been referencing, can you sort of explain with the wire what it does? Does it intercept the pain signal in the nervous system? Is that how it prevents you from feeling pain? I mean,
So what's nice is they all work slightly differently depending on where we put them. So the temporary one sends normal signals to your brain, telling your body that this area is okay and allowing your brain to do other things, to just reorganize and focus on other areas of pain. That breaks the chronicity, we call chronic pain, or the chronicity of pain in the brain. Because when it's happening all the time, those nerves are constantly saying, I have pain, I have pain. We want to break that pain cycle, and that's what that does. The one in the spine, this particular device called the dorsal root ganglion stimulator, it's a very long word, DRG, provides stimulation to a part of the nerve in the back at the first point where the signals are coming in and your body starts to change them and let you know whether it's a good thing or a bad thing. Is it a good sensation? Is it a bad sensation? What is the sensations coming through? And so what it allows us to do, and this is key here, it allows us to provide very little stimulation, meaning you don't feel it. It normalizes the sensation in your leg. So, I'm saying leg, let's say leg. So that if their leg was burning or your leg was tingling or it was in a lot of pain, it just feels normal.
so is this something that people with sciatic pain can use to address that? Because that's painful.
Absolutely. So what I tend to do in my practice is that if patients traditionally have had back surgery and they have chronic pain in their sciatic pain, but everything's decompressed, everything looks okay. We put a little wire next to the nerve that goes down the sciatic distribution, the sciatic pathway, turn it on, and you test drive it. People do very well with that. And then what I've seen a lot of is a lot of older patients who just cannot undergo back surgery. They have chronic pain in their back and in their legs. We can put one of these wires and we can normalize that pain. I have a lot of patients, even in their 90s, that are using this therapy to help them go about their life.
So, Dr. Intercept BVN, what is that?
So when we talk about, this is a very specific thing about back pain, and I'm very excited about this procedure because until, let's just say, it takes a long time to get the data from the science lab to people. So it's been about 20 years in the making for this procedure to get approved. It's been about 7 or so years approved by Medicare, and the 5-year data, when I say 5-year data, I mean in real people, not study people, looking at how much relief they get, we found that this procedure provides durable pain relief in about 80% of patients at 5 years out, meaning 8 out of 10 people, whatever relief you got with this procedure is still there 5 years later. And at that point, they stop looking at it. It's essentially a curative or a more permanent procedure.
So what
is it?
Yeah.
What is this thing?
What is that?
So when we have back pain can come from joints in the back, can come from compressed nerves in the back. This procedure looks at a type of arthritis that affects basically the spine bones where the discs are. So where the discs get degenerative or they wear out, and then there's the bone gets arthritis on top of it, that is a pain-generating area. It's a nerve that goes to that spot and tells us we have pain there. The interesting thing is we never had a treatment for this before. Before, we would look on an MRI, and a patient would say their back hurts, and we would see the discs don't look good, and we would see that the bones are inflamed. And they call them modic changes. They call them all types of, but what it means is on the MRI, they're lighting up with white as opposed to black, and they're having fluid build up in those joints. And when I was a medical student, we were taught this doesn't do anything. We just see those. They're there. It's just a thing that happens when people get older. And now what we learned is that they are a painful part of the back. And so before we would do epidurals, which we may have heard about those shots. We would do ablations and nerve blocks of the joints of the arthritis. Patients would not get better. They would say, my pain hurts. It hurts when I bend forward. It hurts when I'm sitting for a long period of time. It hurts when I'm standing for a long period of time. It just hurts deep in my back. And when we see this change on the MRI, we can do a procedure where we place a needle right into that bone and ablate that nerve. We disconnect the sensor. We shut it off.
That's pretty cool.
The patients that I've seen so far have done phenomenal. I've had people come back with 20 years of back pain, having this problem, have tried everything else, and they're 90% improved. So
Doctor, what is mild and Minuteman?
So I mentioned stenosis and epidurals. So stenosis means narrowing or tightening of the spinal canal in the back. A lot of people get this as we get older. It's almost an inevitability. We're all going to get some sort of arthritis and some tightening. What happens with stenosis is you have this back pain and leg pain when you stand for long periods of time. It could feel like a throbbing or achy pain or a numbing or tingling pain in the thighs. And what happens is a lot of patients will find themselves bending forward and walking with a cane or walking with a walker. We call it the positive shopping cart sign. If you're walking around in the supermarket and you find that you can lean on the cart and just keep going for longer than you normally would when you're walking around the neighborhood, that's a sign that you have this condition. What that's doing is opening up that space. When you stand up straight, it gets tight. When you bend forward, it opens up, and those nerves can breathe. So the mild procedure is something that addresses a component of that problem. There's a ligament that runs up and down like a rubber band that keeps the spine together. When you get this change, the body says, bulk it up. There's instability here. There's arthritis here. We need to get stronger. So it thickens that ligament. That ligament squeezes the nerve. So the mild procedure allows us to shave that ligament all under local anesthesia or light sedation like Twilight when you get a colonoscopy, and open up that space just a little bit, all through an incision the size of a baby aspirin. You're back to normal activity the next day, and we can see improvements in standing tolerance, being able to stand longer and walk longer over the course of a year. So you'll see improvements steadily as that passes. Patients on average that could only stand for about 5 minutes could stand for almost an hour without having to have pain and sit down. And patients could walk an extra 3,000 steps or something like that.
Is this why people tend to start leaning forward?
Yes.
In their older
Yes.
years? And it's harder to pull it back?
Correct.
Okay.
Because it's a natural process. You feel better when you're leaning forward. When you're standing upright, it hurts. So when we do this procedure, patients will find that they can stand a little bit straighter.
So let's just take another topic. You work with other physicians in sort of a global approach to caring for patients. So can you talk about the other doctors that you work with and what they do? And
Absolutely. So that's another thing. I'm a physical medicine and rehabilitation doctor, and I'm an interventional pain specialist. In both of those fields, they are a multidisciplinary field. We cannot treat patients alone. It's not like, oh, I have my pain doctor, that's all I need. We need a team of obvious, physical therapists, occupational therapists. But we work hand in hand with our orthopedic colleagues, our orthopedic joint specialists. We have excellent physicians in our practice. We have Dr. Vishal Mehta, who's a hip and knee orthopedist. We have Dr. Paul Ragusa, who's a shoulder specialist, as well as sports medicine orthopedics. They both practice general orthopedic surgery as well. We have multiple spine surgeons in our practice, both neurosurgery and orthopedic spine. We work hand in hand because if a patient can have a lesser procedure and not need a bigger surgery, then they can work with us. When things progress and we've exhausted some of these options and you still happen to have pain, well, and you haven't considered a surgery, sometimes that's what you might need. There's a reason why we have all these specialties. The idea of a multidisciplinary pain program is to identify the type of procedure or treatment that is individualized to each patient. So all the things I mentioned may fit one person or another, or maybe nobody here at all. But we have options and we have resources to get you where you need to be.
So I want to just turn the conversation a little bit to, this is a little bit about the philosophy of practice, and we've talked about that privately in the past. But can you talk about the kind of relationship you build with your patients and, you know, how you approach their care?
Absolutely. So I think back to my medical training as a medical student and then a resident and how I wanted to practice medicine, right? We all go into medicine because we want to help people. And when I went through this whole process, what I found nice about PM&R, which was the first specialty that I did, and then subspecialized in pain, was that we were able to have continuity of care with our patients. That's the buzzword. I was able to see my patients for a long period of time and watch them get better, and then still see them down the line to make sure that they were doing well. I didn't like the, very fast one and done. We get you in, we get you out, get you in, get you out. Oh, I can't help you. You got to go do something else, see somebody else, and we got to keep moving. This was more about taking care of people, like I would take care of my own mother or my own grandmother. And to that point, a lot of the things I just mentioned, I've done to my own grandmother for pain, including
And to my mother.
And including the peripheral stimulators and other types of injections. So I don't do anything to my patients that I have not done for my own grandma. That's kind of the philosophy of the practice and how we treat our patients in the medical group as a whole. St. John's is a community hospital, and we take care of the community.
So before we turn and open up to anybody who might have questions, I did want to just ask you to share a patient success story, because we all know on my team and in the hospital, so many people are coming to you. We all know a success story, but I would love to hear one from you. That would be great.
It gives me an opportunity to just bring up a different type of pain problem, something called CRPS, or complex regional pain syndrome. This is a very painful problem that occurs to the nerves. It's a problem that we don't really fully understand how it works in the body, but it causes severe pain to light touch. So this patient was unable to wear socks or have a sheet over her ankle when she was sleeping at night because it caused too much pain. What we ended up doing was taking a look at, the medication management that she was doing, which was not helping. And then we moved on to different types of injections called sympathetic blocks, which is a different type of block where we kind of shut down and reboot the automatic nerves that go to the ankle and foot. Because the problem has to do with the foot swelling, not draining fluid, hair not growing. A lot of different things occur that are kind of strange and bizarre, but it has to do with the way the nerves function. We ultimately waited about 8 months or so before she was ready to talk about one of those stimulator devices. And I said, I was encouraging her from early on. She said, no, I just want to give it more time. I want to try more shots. And we didn't get where we wanted to be. So I did one of the 60-day peripheral stimulator treatments. I'm very happy to say that after she did that treatment, it has been about 2 years out now, and she is approximately 90% improved. She's able to wear shoes. She's able to walk on a beach with sand. She's able to do things in her life. She actually retired because of the pain syndrome and now has returned to work part-time, which is wonderful. So that's why we offer these advanced treatments and give everybody the opportunity to get sustained relief with a very minimal invasive procedure, we didn't have to put a permanent implant for her, which 5 years ago, that would have been the only option.
Thank you, Doc. So anybody in our audience today have any questions for Dr. Erosa? No, we covered it all? We're all good? Yeah.
Oh, we have a question in the back. I'm coming to you, sir. I'm coming to you with the microphone. We want our live studio audience to hear him as well. Go ahead. I'll hold the mic.
I really don't have a question for Dr. Erosa. I'm a former patient, and I'm 81 years old, and I had pain in my back for 3 years. I went to the neurologist. They sent me for physical therapy, helped a little, but still the pain was there. I didn't even know there was a pain doctor to the last neurologist I saw, and he says, we can't do anything more. You're going to go to a pain doctor. So off I went to Dr. Erosa, and I've never felt so good in my life. I can walk,
We like that.
and he fixed me, and I love him. He's a great doctor. And as far as the people in St. John's where they did the procedure, I don't know what the hell he did, but he did it right. The nurses there took care of me like a big baby, which I am. So I want to just thank Dr. Rosa, and I want to tell anybody here with the pain, you can get it fixed because there's a doctor like Dr. Rosa. That's it.
That's
It's
amazing.
true. I've
Thank
gone
you
to
so
him
much.
myself. I've taken my mother to him as well. I saw another hand up here. I didn't want to miss anyone. Someone else?
Yeah.
Oh, yes.
Hi, I'm interested in the sciatic nerve. Last few years, I would walk, get a pain in my groin, stop walking. About 2 months ago, I'm in bed and I have an issue coughing with my vagus nerve, but that's a separate issue. I would cough, and all of a sudden, I'd get this severe pain down my leg. I mean, I really, really, really hurt. What makes the sciatic nerve all of a sudden out of nowhere? It wasn't like I was exercising, God forbid, but you know, it just came out of nowhere, seriously. And like enough, you know? I mean, then I heard from my chiropractor that if I'm in bed and the pain, that I should put a pillow under my knees, because if your knee is bent, I guess it stops the flow of the pain. I don't know. I'm so confused.
Do you want me to explain each one of those things? Is that what you want me to talk about?
That would be great. That would be great.
So what's likely happening is you have some narrowing of the nerve as it's coming out of the back, whether it's a disc herniation. We didn't get into the nitty gritty of each spine problem, but like the nerves go in the center and then they exit your back, and there's little holes where they come out of. And those holes are made by the level above and below. So they kind of like overlap. So if the disc kind of shrinks, it can get tighter. And that happens to all of us. That's why I see people say, I've been shrinking. I used to be 6'1", now I'm 5'9". It's your discs are just getting less, and it adds up to a couple inches as we get older.
Getting old is not fun.
No, but we can help you.
But
But we can help you.
That's the point, that we have options to help with that. And so when you cough, that was another one that I was like, okay, so when you cough, you're putting pressure, it loads the spine and the discs. And so if you have a little bit of space there, you've kind of just compressed it. And then your chiropractor is correct. If you were to lift your legs up, what that's doing is it's kind of just relaxing the tension on your low back and flattening your low back out and getting into a comfortable position. That can be helpful. That's one of the stretches that we do for back pain. Now, that being said, like, what do you do about this? What can you do about this? And if you haven't seen a doctor like myself, there's a lot of options that you could potentially try, from different types of specific epidural injections, different types of procedures like I mentioned with the little nerve stimulation or opening up. It depends on how often it's happening. I would also check your hip. Do you have, I don't know if you want to talk about that, but the way you were describing your pain, I would take a look at get a hip x-ray.
Okay, so I could go to an orthopedic doctor.
You
And
could,
an
or you could come see
orthopedist.
us. We
What
can
did you
take
say?
care of you.
So you could start with Dr. Erosa, and if you do need an orthopedic
He'll
doctor,
tell you.
he would refer you to one in our medical group.
Because I really need another doctor. You know what I mean, in the list of doctors.
I highly
No, I-
recommended him.
We need one more.
I understand. I get that patients get appointment fatigue. As we get older, it's a doctor for this and a doctor for that. What I will say, though, to kind of like plug us in as what does anybody know what a physiatrist is? Does anybody know what PM&R is? Just a hand. Anybody know what I mentioned when I say PM&R? He knows. So PM&R is physical medicine and rehabilitation. As a rehab doctor, we see all of the musculoskeletal conditions, all patients with disabilities, whether it's a traumatic brain injury, spinal cord injury, like Christopher Reeves. That's the type of doctor that takes care of those patients. So in my training, I dealt with all of orthopedic care, just non-operative. So if you have a physiatrist, that person can help you with your shoulder, your hip, your foot, your head, your neck. They may not be trained in injections, they may not be trained in surgery, but they could do all the workup, identify the problem, and direct you where you need to go, which is why this interdisciplinary, multidisciplinary perspective comes into play. If I see you and I think you could get an injection in your hip, and you say, oh, my leg feels good, my groin feels good, I feel better, well then if that lasts for a year, we could just manage it like that. If it doesn't, maybe you need to see somebody else if you're really suffering.
Okay, we had we have a couple questions for you, so.
Okay.
Yes. I've been getting shots in my shoulder for years. Cortisone don't work. Never helps.
So if you're not interested in having surgery, or if you are interested in having surgery, okay. Do you have a pacemaker?
No.
Beautiful. That peripheral nerve stimulator treatment was first studied in chronic shoulder pain. The evidence for relief in chronic shoulder pain with that system is 70% or more in patients that have it done. And in my experience, is the most successful area of the body treated, even though I do it for back and knees and all types of other areas. So that would be the next step I would highly consider because I have a lot of very happy patients.
And does an orthopedic doctor do that?
No, an interventional pain specialist would do that. Orthopedic doctors will give, they would do shoulder replacements and joint replacements, which we have an excellent joint replacement specialist. It's fine in the practice. And they may or may not know about peripheral nerve stimulation. Like I said, it's something that we've done a lot of in our hospital and has been gaining a lot of traction, momentum. You can find doctors at every major hospital in the city that do it, but outside in Westchester County, there's few unless they're associated with a healthcare system.
And you've done the most in the country.
Correct.
Yeah.
Yes.
the guy.
To be clear, he's done most in the country.
Yes.
Not the
Okay, we
cat.
have another
Exclamation
question.
point. Yes.
Hi. My question is, my sister has very, very flat feet, like they're collapsed pretty much. And she's tried a bunch of different things, shots and insoles and everything in her shoes. And it seems like the only option left is surgery. Do you have any other recommendations before that? Because even her doctor said the surgery might not work.
Yes. So if she has chronic foot pain, and I'd like to see the images and things. If we are talking about going down the route of a surgical path that potentially may or may not help, and doing like a neuromodulation or whatever, that's a fancy term for spinal stimulation. That's a general terminology path. We can try one of those things that I mentioned earlier for your sister. But again, if it would be something that we'd have to assess on a very specific level, because it works great for foot pain. And if there are a lot of issues with the foot that can, whether it's arthritic changes because of the collapsing foot, I've done that for patients who have what they call Charcot feet. It's a problem where they collapse and they start to wear out the bones, and they're doing great. But it's more of a conversation to have with her because it's a permanent implant. There's a lot of different things. But the short answer is yes, we'd have to discuss her case.
Okay, moving through the audience. The lady with the beautiful red purse.
Okay, so my husband, who was talking over there, has actually eliminated, talk about too many doctors, and whatever you call the appointments or the doctors, too many.
Appointment fatigue.
We've actually eliminated doctors by going to Dr. Erosa. And as far as shots are concerned, it depends who's doing it. Because I had shots done, and then Dr. Erosa did it in a different way, and it worked. So it's worth a try. And I don't get anything out of this. It's just
We're not paying her.
I had no idea
There's
they were
no
going to be
fee.
here.
You have a question?
I want to just piggyback off of what you mentioned. When we perform our procedures, we do them under ultrasound guidance in the office for like shoulders and joint pain, which increases the precision and preciseness of where we're going so that we make sure we're getting in the right place. there is a small percentage of times that you will miss it. And historically, we're all taught how to do them blind. You push here, you feel that, you stick the needle, you put the cortisone, you walk away. And depending on the joint, they could miss. And that's not a dig at anybody who does them without ultrasound guidance. It's just a fact, a statistical fact. And if you do it with ultrasound or x-ray, you are 100% certain that it is where it needs to be. And that's maybe why some people feel a little bit better than.
Okay, the questions are coming, Dr. Rosa. I have
Sorry,
another
sorry,
one from.
sorry.
No, that's wonderful. No, you're very thorough.
I've had pain for years on my neck and my shoulders from, they said my sciatic, scoliosis, like my bone is straight and then so I'm always tight on my neck muscles. So if I'm doing something with my hands, I've been to the neurologist and if they're like, do this, do that, squeeze this, oh, you're fine, and you're out. You know, I've had like x-rays and things and nobody's knows anything. But if I'm like doing something with my hands, like crocheting or peeling like a vegetable, something off the leaves, off vegetable, all of a sudden my neck is so tense and then I get numbness in my hands and like sometimes my hands actually start moving on their own, like my thumb, from the tightness that I get in my shoulder and my neck. And they sent me for physical therapy. I didn't really think it worked. I mean, I went for a while. I was doing a lot of things, and I was just wondering if there's some kind of stimulation they could do in just always this side of my neck.
So absolutely, for muscular neck problems, we would like to see MRIs, nerve tests, all the stuff they did the workup for. Once we see all that, it depends on the part of your neck that hurts. There's something called trigger point injections, where we just literally put a little bit of medicine into the tight muscles to loosen up those knots that are chronic. There's something called cervical blocks, neck blocks. So where there's arthritis or scoliosis that's causing that tension, the nerve that makes you feel that is just laying right on the bone. So under x-ray, we go right there, block it. We can, to your point, stimulate that nerve with that same system, or we can ablate that nerve using heat to just disconnect it and shut it down. So I think that in what you're describing, that in a small percentage of patients, they can get a block and feel much better. That's kind of where what you're describing sounds like to me. You should see us, and we could talk about those different options and do an exam. The difference between us and neurology is that we are interventional. We will intervene on that problem.
Is that covered by insurance?
Yes.
This stuff, okay.
Okay, I'm moving to this side of the room.
Yeah.
Yes, sir. Here we go.
Yeah, I just wanted to ask about insurance. I missed part of the introduction, so I don't know about the insurance, how insurance works with all these procedures, these new procedures. So maybe somebody can answer the question.
He can.
Does insurance cover everything, or?
Absolutely. So Medicare covers everything, okay? All the things that I mentioned are covered under Medicare. Now, managed Medicare plans, there can be some difficulty, which is why you see a lot of stuff in the news going on with insurance companies and how they've been taking money from Medicare and not providing the same care that Medicare is supposed to provide. The government is trying to fix that. That's a big thing that's been going on. It's been before the election. Hopefully now things get resolved. So what ends up happening is if that happens, you have to have one of those plans that's managed that is saying we're denying procedure X. We have routes to fight with the insurance and fight with them up to an appeals level at the state level with the courts. I've actually been on some calls to have these things overturned where I had to give testimony to the appeals court for this. But that's not, that's few and far between. Then I would say 95% of everything that we do is covered even by the managed Medicare plans. Some of the newer ones may have some issues, but we're doing a lot of them. We're getting most of them covered.
And commercial plans?
Oh, commercial plans, that depends. Depends on which commercial plan it is.
Okay,
Yeah.
all right.
Okay, here
Yes?
I come.
Yeah.
I'm going to hold it for you, honey.
Dr. Erosa, hi. Is there anything with the hands with arthritis that can be done? Because, like I had mentioned, I had a bad fall, but somehow that kind of went away. I tried therapy, but then I've been told now the thumb has arthritis here, it has it at the joint and all. So, like, to try to hold a book or sometimes to write and all, that hurts.
From an interventional perspective, I do ultrasound guided thumb injections. We do them all the time in the office. You see the joint that has arthritis, we put medicine right in it. That can be helpful. And then depending on occupational therapy, paraffin baths are actually really good. You can pick one of those things up on Amazon, like they do at the spa or at the nail salon, and you kind of put your hand in that moist, I don't know how you call
wet
it, thermal, that wet heat
That wet heat.
penetrates deeper, and you can do that on your own at home. And then there's some braces and things that if you really were having a lot of trouble with certain activities, we could talk about.
Well, they had given me, I tried going to the doctor at St. John's, the hand specialist.
Uh-huh.
But like in the orthopedics just said you have arthritis at this joint.
Yeah.
Then when I went to him, he says, well, it's down here. But like I tried therapy, and the therapy made it worse because all the therapy is using your thumb to do different things. So I quit the therapy. But that's why I was wondering, is it possible to get something in the hands?
Absolutely, we can, and we could even, depending on the location of the pain, if we got to that point, some of those stimulator therapies can help. I've done it for patients with chronic hand pain, but again, much less because shots help people. So
Right.
we just start with the least thing first, and then we work.
Okay, thanks a lot, yeah.
Anybody else?
Just one thing. Why do you see, do not take aspirin with Tylenol too? What is the reason for that?
For those,
So I think what you're thinking of is aspirin and like ibuprofen or Aleve. All those medicines can irritate the stomach and thin the blood a little bit, and they can put you at an increased risk of having a stomach ulcer or stomach bleed. So they don't want you to be taking multiple of those medicines. So if anybody here is taking Advil and ibuprofen or Motrin and Aleve or a prescription and one from over the counter, you shouldn't do that. It's not good for your stomach or for your kidneys. You should only take one of those. Tylenol actually is okay. Tylenol is different from all the other ones. So you can take a Tylenol and an ibuprofen, but I would talk to your doctor about that because that all depends on your heart health, your stomach health, and your kidney health.
If I take a statin
a statin.
and Tylenol once in a while, but I'm supposed to take a baby aspirin every day.
Tylenol and the baby aspirin are perfectly fine. If you stick with Tylenol for your pain relief, it's very tolerant with other medicines.
Well, I was 90% blocked
Oh, wow.
in my neck.
Yeah.
So a year and a half is going on.
Okay.
Okay.
And they said you can keep taking the 2 of those.
That's safe. Yeah, you could keep taking those.
We have a follow-up question, Dr. Erosa?
On that one. If you have like arthritis pain, like knee pain or what, something to get in my hands, is it better to take like the naproxen Aleve or like ibuprofen, like Motrin?
When it comes to that, I think the basic rule of thumb that I like is like ease of use. So I like naproxen as you take it twice a day. It's like easier than Motrin or something like that where you have to take up to 3-4 times a day.
Better for inflammation than the other?
They're all anti-inflammatories. There's some statistics, but they're mostly comparable when it comes to things. There's some other numbers with prescription strength ones or prescription types that are not available over the counter, but I don't want to get into all that.
Okay, yeah.
Okay, I think we're done with the
think we're- I
Q&A
think we're
portion. I'm
good.
going to turn it
So-
back over to Denise and Dr.
Yeah.
Erosa.
So I want to thank our live audience and our live stream audience for joining us today on our very first YouTube show, educational program with Dr. Erosa. So let's say thanks to Dr. Erosa.
Thanks, everybody. Thank you for your questions. Thank you for your time.
Thank you very much.